Hello everyone, welcome to today's lightning talk session. My name is Katsi and I'm joining you all from the traditional, ancestral and unceded territory of the Musqueam people. In today's session, you will hear 6 different presentations from our brilliant speakers. Each presentation will be about 5 minutes long and will be followed by a 3-minute question and answer period. You can ask any questions you have for our speakers through Whova. You should see a Ask a Question button on the bottom right-hand corner of your screen on the Whova platform. We also ask that you submit your questions while each speaker is presenting. That way we can get started with our question and answer period right away. If you like any questions coming into the Q&A box, please give it a thumbs up. I will try my best to answer the most popular questions first. If your questions do not get answered in our live session, presenters will be able to type out responses in the Q&A box. There will be one winner from today's session. The winner will get a certificate, social media shout out, and an invitation to present a workshop at next year's conference. The winner for the session will be announced at the daily wrap-up at 3:45 p.m. PST. And to vote on the winner, please select the polls option on the right side of your Whova screen and vote on your favorite talk. With that being said, let's get started. Our first lightning talk will be presented by Jonathon Gormick on VCH-VFRS Combined Overdose Response Team. Jonathon, you have the floor. Please feel free to introduce yourself and present whenever you're ready.
Hi everyone, hi Katsi. Actually, we're just waiting for John to join. So if it would be all right if we skip to the next speaker first and we'll come back to John when he's able to join the Zoom chat.
For sure. So next up, I'd like to invite Craig Hutton, who will be presenting on exploring socioeconomic influences on mortality and mental health in Vancouver from 1995 to 2017. Craig, feel free to take it away.
Okay, should I be sharing my screen for this? No. Okay, thank you everybody for joining me. I'm Craig Hutton. I'm a data scientist who's working with the BC Ministry of Social Development and Poverty Reduction. I'll tell you a little bit about some socioeconomic influences on mortality and mental health in Vancouver from 1995 to 2017. So why focus on Vancouver and the downtown east side neighborhood? Well, the downtown east side has deteriorated in recent years with increasingly visible rates of homelessness, mental illness, criminal activity, and opioid overdoses. Has a reputation as Canada's poorest postal code, and nearly 2/3 of homeless residents live in the downtown east side. How can we move forward? We can learn from data. Little research previously has been able to use population level data, but now we can with platforms like BC's Data Innovation Program, which I'll show you some results from today. This provides us with access to millions of records from multiple sources. We'll be focusing a little bit more on income assistance and health records today, which we examined over the last year. And then later we'll look at socioeconomic factors, which is what I'm currently working on. So in this part of the project, we took demographic information from MSP billing records, and we joined that with income assistance, death records, physician billing records, and hospital separation records. It gave us 23 years of data for over 1.7 million residents of Vancouver. And our first question that we examined with this was, how does social assistance utilization differ in the downtown east side from the rest of Vancouver? And what we see is that the proportion of downtown east side residents, which is the red line that we see at the top, relying on income assistance is over 8 times higher than the most other parts of Vancouver, which is the blue line at the bottom, sitting at about 20%. And when we instead look at life expectancy and mortality, when we look at the vital statistics death records, what do we see for the downtown east side comparing that to the rest of Vancouver? Just overall all-cause mortality is what we're looking at, or what we will be looking at. On the left panel, we see the mortality rate. And what we see is that the annual mortality rate in the downtown east side is about 2 to 3 times higher than most other areas of Vancouver in the blue line at the bottom. And on the right, we see downtown east side residents tending to live about 10 to 15 years shorter than residents of other areas. And then, so if they're dying more often, what are they dying from? We're interested in breaking this down into different health categories so we can see if there are areas of greater need. To do this, we took thousands of raw diagnosis codes, or ICD codes, and assigned them to 38 different health categories, 7 of which were related to mental health. And I want you to shift your attention to focus on the green bands or bars that follow, where we looked at opioid-related conditions, for example. And what we see in the far right panels for downtown east side residents, we're focusing on the green bars, drugs are the most common cause, or identifiable cause of death for income assistance clients living in the downtown east side. If we look at the hospital separation records instead, what are the main causes of hospitalization in Vancouver and the downtown east side? And again, we're going to focus on the green bands here. So if we look at the lower row versus the upper row, the green bands take up a lot more space. And that represents, in this case, psychosis, substance use, and mood or anxiety disorders. They're major causes of hospitalization for income assistance clients. We also see a little bit of that for non-client men in the downtown east side. Lastly, why do Vancouver and downtown east side residents visit healthcare providers and physicians specifically? Again, the green bands here noticeably taking up a lot more space in terms of overall health utilization, where substance use and opioids especially and mood or anxiety disorders are dominating. And that's the lower row versus the top row. And in summary, we can say that at least 1 in 5 downtown east side residents are relying on income assistance versus an average of 1 in 40 only elsewhere in Vancouver. The mortality rate is over twice as high, life expectancy over a decade shorter in the downtown east side. And the main message is that Vancouver is facing a crisis of mental health, not just drug overdoses. And I just wanted to provide some credit to the sources of information that we use. So my ministry, SDPR, we also used information from the Ministry of Health and from the Vital Statistics Agency. And thank you very much for the Data Innovation Program for making this possible. I had to rush through much of the details, but you can learn a lot more about this project from our Knowledge Update report, the PDF of which is shared on the Whova event page for my Block 2 workshop from 12 to 1 p.m. today. I'd be happy to take any questions if there are any.
Thank you so much, Craig, for such an insightful presentation. Now we'll be moving on to a 3-minute question and answer period. So audience, please feel free to send any questions you have on Whova and I'll read them out as they come in. And to get us started, I will read out the first question. So how is your data and research being used by the MSD to change policies within the income assistance system that have detrimental impacts on the health and lives of people reliant on that system?
Thank you for the question. The research is still pretty early on. The platform, the Data Innovation Program is quite new. So we're still adding in a lot of the data sets to figure out what is going on. But the information will hopefully be used or is intended to be used to develop better policies to help allocate resources where they're more sorely needed to help income assistance clients who are struggling the most. And through efforts like this, we're identifying who is at greatest risk and where we can best put those resources. Part of what we're also trying to do is to hopefully promote awareness of what is happening and to help counteract stigma, which we see as one of the largest problems that our clients are facing.
Thank you so much for answering that question, Craig. Before we move on to the next talk, I have one more question for you.
Sure.
So, is this technology only available in British Columbia, as it would be interesting to do this in other jurisdictions?
As far as I'm aware, it is unique within Canada. However, I hope that other provinces will see what we're doing and try to follow suit in terms of just simply combining information across different ministries and organizations within government. Because really, when we're trying to address a complex problem like overdose or like poverty, we need to consider multiple sources of information, right? And the only way to do that is to work together really across ministries.
All right, thank you so much, Craig, for the wonderful presentation and answering all those questions. Now we will be moving on to our next lightning talk, which will be presented by Jonathon Gormick on VCH-VFRS Combined Overdose Response Team. Jonathon, you have the floor. Please feel free to introduce yourself and present whenever you're ready. Jonathan, unfortunately, we can't hear you. Would you be able to leave the audio on the Zoom call and rejoin? Yeah, Jonathan, unfortunately, we still can't hear you.
Something you could try, Jonathan, is under the audio button at the bottom left-hand corner of your page, there should be a little arrow. If you click that arrow and just make sure that you click same as system, that sometimes fixes the glitch.
Anybody? Is that working?
Great, we can hear you now.
Fantastic. Sorry for the delays. Do you want me to pick up where I was?
We actually didn't hear any of it, so if you wouldn't mind restarting, that'd be wonderful to hear your whole presentation.
Excellent. Do you want to go back to the first slide? Is that under my control, or is that?
I will do that. And take it away.
Okay. Sorry for the delay. Thank you very much for having me this morning. My name is Jonathon Gormick. I'm the captain of Strategic Health Initiatives for Vancouver Fire Rescue Services, and I'm also the VFRS half of the Combined Overdose Response Team, which is a first of its kind initiative that sees Coastal Health and Vancouver Fire following up with people who've experienced a 911 call for overdose in the days following it to check on well-being and try to connect them with the supports and services that reduce the likelihood of a future overdose. Just briefly, obviously, Vancouver Fire provides pre-hospital care to the City of Vancouver and UBC endowment lands, and about 10% of our call volume is overdose related. And the VCH Overdose Outreach Team is a group of social workers and specialists who try to connect people with all sorts of treatment and care and health options within the community. What we bring is obviously a relationship with the patient and the 911 data collected as part of the call. And the Overdose Outreach Team brings an absolutely encyclopedic knowledge of the services and supports that are available, and they can continue the relationship forward after that introduction has been made. What we do is build a list of patients, and then when we're on scene, we ask the patient if they consent to their information being shared, at which point the social worker can either address problems right there or set up a relationship to deal with ongoing problems or work with the patient on an ongoing basis. Really, I look at the overdoses we attended over the period of a week. I filter out some things that don't fit within our mandate, and then I build a list and we try to connect with each of those people individually as soon as we can. This is addressing people who are falling through the gaps of the normal referral system. So people who decline transport to hospital, who self-discharge, or who don't have contact information because they're struggling with homelessness or housing insecurity. All these really, really hard to reach patients. Why fire? I get asked this a long time. Obviously, there's a legal side that we have access to the 911 data, but really when we're reversing overdoses, we're just keeping people alive. And what we really want is healthy, safe communities that are thriving. And I think we have an ethical obligation to address factors like that. There's some obvious goals and some less obvious ones, including things like we're looking to reduce the compassion fatigue that firefighters are feeling. We're trying to increase collaboration between care providers and really improve the overall patient experience through the healthcare system. We started this in January of 2019. It took about 8 months of planning and legal work to get off the ground. Another really important milestone, recently we got funding from the city to make this a dedicated position at Vancouver Fire. Since we started, we've connected 177 people with care and support. And I think it's important to note, no surprise to this audience, but over half of those people were outside of the downtown east side, clearly demonstrating that this is a crisis that doesn't know demographic or geographical borders. We've got fantastic examples of people who've been helped, people who were disengaged with OAT, people who the team couldn't find because they didn't have a fixed address, but we were able to locate because we used the call location, the team finding services that worked around people's school or work needs. Out of all those people that declined support once we contacted them, very few of them flat out declined help. The vast majority were already connected with a service that we would have connected them with. I thought there would be much more reluctance talking to someone who essentially showed up to cold call at your doorstep and talk about a recent overdose, but people have been extremely receptive to it, especially in outlying areas, I think, because someone shows up that knows what happened, that's there without an agenda and just really wants to help improve your life or prevent a further overdose. We also thought maybe being in a uniform would prevent effective barrier because it resembles law enforcement. And we tried a few iterations and landed on a muted version that's essentially just a crest and my name rather than having rank and shoulder patches or anything that looks authoritarian or like law enforcement. Frustratingly, what we're really trying to do is prevent repeat overdoses, and that's the toughest metric to capture because we don't collect a unique identifier, so we can't definitively say that a certain person has not overdosed again, but the anecdotal evidence certainly points to that. Two big groups have come out of this. One that may be outside of the downtown east side, typically they're using, this may be their first or second overdose, they're using alone, but they're dealing with stigma, they don't know what services are there, and they don't know how to access them. The other group, generally within the downtown east side, probably not their first overdose, dealing with multiple concurrent problems, know what services are there, but either need help re-engaging, finding alternate services, or even just that helping hand of someone taking them to a doctor's appointment to help them get re-engaged. We want to grow the team, definitely. We're going to continue some fire hall training sessions with frontline staff. We'd like to work more with underrepresented groups to see if we can improve our service delivery and really overarchingly just break down the silos between pre-hospital care, primary care, acute care. And I owe a huge debt of gratitude to my two colleagues at Vancouver Coastal Health, Chris Van Veen and Misty Bath, without whom I couldn't have got this program off the ground, never mind see the results that we've seen so far.
Thank you so much, Jonathan, for such an interesting presentation. Similar to earlier, we'll be moving into a question and answer period for about 3 minutes. So to our lovely participants, please send in any questions you have for Jonathan and Huva, and I will read them out as they come in. And to get us started, I have one question from Carla. So she says, this seems really great. Is the EMS involved at all or just fire?
Currently, it is just fire. When we started to build the framework, the invitation was extended to EHS. It works with fire because it's controlled at the city level. So, you know, compared to a large provincial body, it was much easier to build a pilot project, especially with the flexibility we needed to figure out what was the most effective delivery model. I'd be happy to see it expanded into other municipalities. And there's a few within BC and at least one within Alberta and one within Ontario that are hoping to copy our model and do the same kind of work.
Thank you so much, Jonathan. So we have another question from Andrew. What strategies do you use to engage people in treatment / avoid repeat overdose?
I think the biggest strategy we have is arriving without an agenda. We're not trying to push treatment or detox. It's fantastic if that's what people want, but what we do is show up, ask how someone's doing, and say, what can we do to help you? We don't care if they want to continue using, we just want to make sure that they're doing it in a safe way and we can provide those options. And like I said, we don't have any agenda. We try not to offer specific solutions that might optically seem like they suit that person to reduce the chance of either overt or any other kind of bias. It's just showing up and saying, you know, what can we do to help you? And we run through a few options, but it's the lack of having an agenda and it being completely patient-driven solutions that I think is most effective.
Thank you so much, Jonathan, for answering those questions. So that wraps up our question period. To our audience, if your question was not answered during this session, please note that our presenters will be given the opportunity to answer questions directly on Huva as well. So next, I'd like to welcome Peter Johnson and John Christy Johnson, who will be presenting on Sparing No Pains, Soothing the Opioid Crisis During a Pandemic. Speakers, you have the floor.
All right, good morning, everyone, and a virtual welcome to everyone. I'm Peter.
And I'm John.
Today, we will be discussing the opioid crisis within the context of our current pandemic and the findings of our literature review for policy recommendations to soothe the ongoing pains inflicted on our society by the crisis.
So recent comments by Canada's Chief Public Health Officer, Dr. Teresa Tam, have highlighted the need for nationwide attention on the opioid crisis. Regions like BC reported 170 overdose fatalities in May alone. To put this in context, this surpasses deaths due to coronavirus.
So between January 2016 and December 2019, the Canadian Public Health Infobase reports 15,393 deaths, 19,377 hospitalizations, and more than 21,000 suspected overdose cases.
While exact numbers remain unpublished, the onset of the COVID-19 pandemic appears to correlate with a surge in overdoses, with Ontario at 125%, BC at 140% in comparison to months last year.
Now, many specialists, including addiction specialists, have suggested self-isolation and social distancing measures make it particularly challenging for people who are actively using opioids and other drugs, or people who are very early in recovery.
Furthermore, the pandemic has reduced access to support groups for patients in rehab for opioid addiction and make them more prone to relapse. The rise of opioid overdoses in the past decade has been attributed to contamination of illicit drugs with fentanyl and its more potent analogs.
Now, fentanyl is 50 times as potent as heroin, and drug dealers may mix fentanyl with drugs like heroin to provide the same potency of stimulation at a reduced cost.
And this is problematic because overprescribing opioids is another path for opioids to be misused. In fact, prescriptions for opioids in hospitals and pharmacies have increased by more than 3,000% from the 1980s to 2018, with over 20 million opioid prescriptions dispensed in 2016.
However, the increased dispensing of these drugs can result in mischievous or ill-informed practices, including sharing with family members, prescription fraud and forgery, and street use and internet selling.
In 2017, Health Canada conducted a survey that actually suggested nearly a third of those who used a prescription opioid had no prescription.
So what do we propose to do? So for our purposes, decriminalization and prohibition will be sidelined due to the broad scope of its policies, practices, and ethical considerations. So we suggest less drastic measures, but still evidence-based, transparent, and tactful strategies to curb the overdose cases.
First, we propose to increase access to a safer supply of drugs. A targeted approach to offer safer supplies and education to high overdose incidence geographical areas can be used.
Now, for example, First Nations communities in BC have been seeing a significant higher rates of cases. So while stringency on dispensation guidelines and using conservative volumes of prescription opioids could be used for pain relief, the same cannot be said for cases of addiction patients.
More access also ought to be provided for those addicted to illicit opioids to access safer supplies of drugs like methadone, buprenorphine, Suboxone, or slow-release oral morphine. Advantages to this is that you can get rid of the hallucinogenic properties.
Then second, the more investment is required for medically safe consumption sites. So tools for harm reduction have been really associated with lower overdose mortality rates, and it can hold a lot of promise.
With the pandemic, provinces like Alberta are especially at risk, where the provincial government stripped funding for safe consumption site programs. So reinvesting in these essential programs can prevent social discord and reduce potential overdose deaths.
Now, finally, we propose the provision of flexibility and further funding to help translate in-person healthcare to telemedicine. Understanding that compliance is vital for effective rehab, novel forms of telemedicine can serve to replace conventional therapies.
And instead of support groups, remote patient monitoring tools and technologies are beginning to be implemented with notable results. So mobile apps, remote sensors, telepsychiatry initiatives can be streamlined to reach the remotest areas and overcome geographical barriers.
So machine learning algorithms that model and predict behavioral responses and select interventions have been effectively used to create robotic therapist simulations like Alice.
And if these programs can be further researched and piloted as therapeutics for addiction patients, there will likely be an increase in compliance with the rehabilitation and in turn, addiction recovery, and in turn, hopefully less overdoses. Thank you.
Thank you.
Thank you so much, great speakers, for such an engaging presentation. So to the audience, if you haven't had the chance to do so already, please send any questions you have on Whova, and I will read them out. And just a reminder to please avoid sending questions over the Zoom. So just in case we aren't able to cover the questions during the live presentations, the speakers still do have the opportunity to answer questions through the Whova platform. So I'll give everyone a minute or 30 more seconds to ask any questions they may have. All right, in the interest of time, we will be moving on to our next talk. But as always, if you do have any questions for our speakers, please feel free to send them over Huva. So our next presentation is by Andrew Johnson, who will be presenting an opioid agonist therapy, a synthesis of Canadian guidelines for treating opioid use disorder. Andrew, you have the floor.
Thank you very much. Can everyone hear me? I hope so. Great, thank you so much for having me. We called this talk a practical approaches to confronting a crisis, because the project that we've worked on here at the Center for Addiction and Mental Health with the leadership of folks like Dr. Peter Selby and through the hard work of folks like Hemas Bogar is really to create guidelines. Guidelines within medicine provide the standard of care that people are expected to work within. And within a highly regulated profession like medicine, where there are very strict standards of care, people need to understand how they need to be operating. Guidelines are created through evidence, through clinical experience, legislative limitations, etc. And what their goal is to help clinicians know how best to get the best clinical outcomes for their patients. They're relied on across the colleges that medical professionals work within, and are really a standard that they're expected to uphold. In Canada, at the moment, we have a rich ecosystem of guidelines. There are many of them, up to 18 that we looked at for this project, and perhaps more that we never unearthed. But one of the things that creates is a bit of confusion within the overall system of which guideline to follow, which evidence to be looking at. And what we at the Center for Addiction and Mental Health, supported by a large number of the medical regulators within Canada, is to create a single synthesized guidelines. So that is that we're bringing together guidelines from CRISM, et cetera, in order to create concise, action-oriented, understandable, and applicable guidelines that physicians and their allies within care can look at and understand what the clear expectations are for them. One of the things that this helps is to support new clinicians coming in so that they know what the standard of care is. In order to get at our guidelines, we used a process of working with subject matter experts, medical regulators, and a robust external review board. And between them, we created an iterative process in order to land on our synthesis guidelines. Opioid agonist therapy, a synthesis of Canadian guidelines for treating opioid use disorder. What's in the guidelines? We've got basically the continuum of care, what you need to understand about engaging folks within this area of treatment, specific types of medications that can be used, how to handle specific cases such as hospitalized patients or incarcerated patients, how do you deal with transition age youth, discontinuation, etc. What we're committed to at CAMH is to try and keep up with the emerging guidelines, to predictably set out a set of guidelines that people can look at, refer to, and rely upon. We're going to make that available on our website, as you can see here, and through paper print copies for those that want them. One of the things that the guidelines can't do is do the job of regulators. Regulators are not endorsing these guidelines, but we have certainly worked in side by side with them to create something that synthesizes what is out there with a very rigorous process so that they can look to our guidelines as guidance for working with their clinicians to set out what is that standard of care. One of the things that we don't talk about are things where there is not sufficient evidence, such as the issue of safe supply. Unfortunately, we know that this is a very hot topic and a really important area to consider, but there is simply not enough evidence at the moment to construct that within a guideline document. Thank you very much.
Thank you so much, Andrew, for such an interesting presentation. Now we will be moving on to our Q&A period. And to start us off, I have one question for you. Have similar national guidelines been made in other countries? If not, how can other countries learn from the Canadian guidelines?
That's a question that I actually don't know the answer to. We really focused in on the Canadian context. Perhaps we should have looked to see what folks around the world are doing in this space, though we certainly did look at methodologies for creating synthesis guidelines in other jurisdictions. Perhaps one of the other panelists or somebody who's attending can let us know if a similar sort of strategy has been attempted.
Thank you so much for answering that question, Andrew. So our next question is, do you provide guidelines for older individuals?
There is, in fact, and there has been a brand new set of guidelines that has been articulated around treating older adults that we've brought under the umbrella of these guidelines, yes.
All right, thank you so much, Andrew, for answering all those questions and for such an interesting presentation. Next, I'd like to welcome Nancy Chow to share her presentation on Episodic Overdose Prevention Services, Evolving Harm Reduction Within Healthcare Facilities. Nancy, feel free to take it away.
Hi, everyone. I also want to invite Andrew Kerr, who's my co-presenter, will be presenting on the implementation of Episodic Overdose Prevention Service, also called EOPS. Initiative that is evolving harm reduction within healthcare facilities. So I'm the clinical practice lead in Vancouver Coastal Health for the Regional Overdose Emergency Response and Harm Reduction Program and the Regional HIV Prevention. And Andrew Kerr is also a practice lead for the interior health in the Mental Health and Substance Use Network. We would like to begin by respectfully acknowledging that the work done in Vancouver Coastal Health regions lie on the traditional homelands of the Coast Salish people, and particularly in Vancouver is the Musqueam, Squamish, and Tsleil-Waututh. And in the interior health, Andrew?
Moving right along.
Okay, so in the next few minutes, we'll be discussing the context and the rationale of implementing EOPS, what it is, its impact on the healthcare system and on the people who use substance, and where we've implemented as well as where we hope. And you'll see here, based on the BC Corners data, as you know, there's been a steady rise in the death rate in our province due to illicit drug toxicity. And in 2018, it started to drop due to good harm reduction strategies, but started to rise again in 2019 due to COVID. Also, from the Corners data, this is a table that indicates the location of illicit drug toxicity deaths in the last 4 years. And you'll see in medical facilities as well as outside. And then, as you can see, there are cases of overdoses occurring in the healthcare settings in the surrounding areas. There are often no supervised consumption sites on site or nearby. In any situation, staff encounter clients who intend to use illicit drugs, and these clients are leaving against medical advice. So we've been directed by the ministerial order that authorizes health authorities to establish overdose prevention services in any place there is a need. And you can see here kind of the rationale of what we are about to talk about.
So
And I'll
this
let
study,
you.
this study here represents, it measures the impact of the three main interventions of opioid agonist treatment, overdose prevention, and take-home naloxone in examining the impact of those interventions on death rates. And without these interventions in BC, they predict that the overdose deaths could be up to 2.5 times as high without those three main interventions in our province. And with overdose prevention or supervised consumption, if you didn't know, at its very heart is a safe place for a person to go use an illicit substance and be monitored for overdose. And there's a number of benefits, as you can see from the little infographics, as well as the great advantage of connecting people to healthcare.
In 2019, both Andrew and I were part of a provincial working group, an EOPS working group that developed a protocol to guide the implementation of on-demand consumption monitoring. And in 2020, due to COVID-19, really pushed the endorsement of this work.
And episodic OPS is different than a fixed site in that it allows the consumption of substances in any healthcare or social service setting, hospitals, community health centers, shelters, and it's delivered by anybody who's trained to respond to overdose.
And really have the impact on offering EOPS in healthcare facilities. It promotes dignity and respect for all clients, promotes client-centered care, reduces barriers for people who use substances to engage in health services, reduces stigma associated with substance use. And as you can see, we've worked really hard in the last couple of years to really implement this in various settings, mainly in the community health settings, such as primary care settings. Some of the clinics are Sheway, Foundry, Ravenston Community Health Clinics. We also in shelters as well.
And in interior health, we've targeted mostly rural communities that saw spikes in overdose activity. And the EOPS service is integrated with community health and the acute care. Many times it's small rural hospitals that have all health services together.
So really, some of the focus we want to do is emphasis on the need for EOPS in acute care. There's often high risk of people with substance use that are admitted to hospitals. They're leaving against medical advice due to abstinence-based policies. Therefore, we not receiving complete medical care.
And as far as evaluation of it, we want to, the main things we're looking for is number of consumption events and overdoses, but then also other great services that are provided, such as harm reduction, supply distribution, drug checking, minor nursing care, and so on. Thank you very much.
Thank
you so
you.
much, Nancy and Andrew, for the great presentation. Now we will be moving on to our Q&A period. So the first question I have for you is, you mentioned 3 different interventions. Which intervention is the most used and why do you think that is?
You want to take this one?
Yeah, so interestingly, in BC, take-home naloxone is an incredible intervention. And in May, the BC CDC recorded their 1 millionth take-home naloxone kit that was distributed. And all 3 of those interventions continue to be high priority for all health authorities to increase the capacity and access to.
Thank you so much for answering that question. So my next question for you both is, why did you choose to target rural communities in the interior with EOPS?
Yes, so with that was a targeted intervention that saw spikes in overdose deaths and non-fatal overdoses in those communities. And it was also paired with some British Columbia Ministry of Health targeted funding, where the nurses that were hired in those communities have a combined role of EOPS, so monitoring people for overdose who consume a substance, as well as being nurse prescribers, which is a new service in BC. So an interesting combination of roles that really in small communities that have really limited addiction resources, it's one person who's able to provide 2 really important interventions.
Thank you, Andrew. My next question is there any research on utilization of OPS by people admitted to inpatient mental health services?
So this is something I think is still a very novel initiative, where this is something we want to socialize in mental health and in acute care services. So we know that there is a need due to the high risk of patients leaving against medical advice, or perhaps even using on-site unsafely, either in areas where there is no monitoring. So this is something that is a big need, and would be we'd welcome an opportunity to be able to implement and then evaluate.
Thank you so much, Nancy. So next up, we have, in terms of opioid use in acute care settings, how do the acute care settings deal with clients bringing it into hospitals? So for example, contraband or search policy.
Yeah, it's Andrew. So interesting question. And there are policies that are kind of governed by, Controlled Drugs and Substances Act. And as we implement these, we have to figure out strategies. One of the main strategies in facilities that are doing this is providing a safe for patients to store their belongings in, so that staff don't have to interact with it, and kind of looking at all the related policies of, if somebody comes into hospital and they're unconscious and they're not able to consent to searches or anything like that, we have to recognize that for someone with an opioid use disorder, who may not be willing to accept an OAT or a prescribed opioid and want to use their own substance that they brought with them, that if that's the choice over the other options, that we want to support that option for them.
Thank you, Andrew. So next up, we have, how do you set up an EOPS in a social space?
Yeah, I think reach out. And so in British Columbia, reach out to your local health authority, and they will provide, the guidelines are available on the BC CDC website. And then your local health authority representatives will help you kind of put together the policies and procedures and the legal authority and all that stuff, so that you can deliver that service safely.
Thank you so much. So our next question is there a goal to have an OPS in every hospital setting in BC?
That's a good question. I think Carlin, who's going to be presenting next, will be able to speak to that. But the goal is to have some level of harm reduction service, such as, if not as fixed site, an episodic overdose prevention site, which is a bit more feasible because it's a less costly initiative. But the goal is to be able to allow patients feel safely to use their substance if their substance use is not met within the offerings of the hospital settings.
Thank you. So I have one more question for you both before we move on to our next presentation. Can those policies be shared, as I'm looking into it for a hospital here in Sudbury, Ontario?
Absolutely. And I see that Carla put her email there. I will follow up with you, Carla, afterwards.
All right. Thank you so much, Andrew and Nancy, for the wonderful presentation and for answering all those questions. And to wrap up our session, it is with great pleasure that I invite Carlin Patterson to speak. So Carlin will be presenting on overdose prevention in acute care, lessons learned from opening St. Paul's Hospital OPS. Carlin, you have the floor. Please feel free to introduce yourself and present whenever you're ready.
Thank you. All right, so my name is Carlin Patterson. I'm a nurse educator at St. Paul's Hospital here in downtown Vancouver, and I'm here to talk to you and share some lessons that we learned from opening the OPS at St. Paul's Hospital in February of this year. So the site that we opened is run with a 2 LPN staffing model. It has 4 booths, as you can see here. So it is a small site, and it's for patients only of St. Paul. So we can be a little bit flexible with that definition though. And I will refer to OPS participants as patients during this presentation. I also want to acknowledge that we had a much easier path opening because of this team here. The Thomas Donaghy OPS was on site at St. Paul's since 2018, and they really paved the way for us, but they moved this year, which is what prompted us to open a site inside. So once you've determined a need for an OPS, your next steps are really beyond the scope of this short presentation, but I will list here organizational approval, securing funding, an ethics consult, and selecting your location. Now we'll get into some tips from our opening. So these are things that went well for us, some oversights, and then things that we underestimated in importance. Keep in mind that we were crunched for time and resources, but that's not surprising really in this line of work. So you are going to be developing unique policies and procedures. And the goal here is really to balance the lower barrier methods that are in the community with more stringent hospital ones. So I would reach out to any available resources. For example, I spoke a lot with Royal Alec because they have a safe consumption site there. You'll also want to meet with professional practice or the equivalent at your site because they are going to be approving and reviewing all of your documents and procedures. So you want to make sure you're on the same page with them. And of course, engage patient partners as much as you can. For your overdose response, some considerations are what the current hospital overdose procedure is. Yours will differ though, because this is for a witnessed overdose compared to unwitnessed, which would be like on the inpatient units. Compare that with community site responses, and then consider your staffing levels as well. Engage ICU physician leads and nurse educators early on. This is really important. It's a unique space and situation. So in my experience, there has been some confusion if you have to call a code blue around roles and responsibilities. So look for feedback from them and maybe run some mock scenarios if you can. Next, ask yourself who to engage before opening. So for us, there was a long list, but for example, IPAC, occupational health and safety, risk management, security, violence prevention, pharmacy, and you'll want to connect with the offices and units around where your site location is going to be. Also send out a site-wide communication, letting the whole organization know that you're opening, and then create a plan of how you're going to communicate this opening to patients and the hours. So a somewhat unexpected piece for us was that there was a lot of need for education on the inpatient units for their staff. They felt uncomfortable, and this highlighted sort of some education gaps there. So I would suggest being proactive and running in services on the units prior to opening. You can also make one-page practice pointers on post-overdose monitoring and unit responsibilities, offer tours of the site, and attend new hire orientations. So you will, of course, come across some staff that do not support the OPS. Assuming a harm reduction approach doesn't work with them, I would focus on the benefits, these benefits for them. So patient safety, of course, first and foremost, less substance use at the bedside, less overdoses, which is less workload for them. So maybe I was a bit naive in thinking that other departments would be really supportive of the OPS work, but overall, I haven't found that at all times. So the staff at the OPS really do work separate from the rest of the hospital. So it's important to develop a really strong support team for them. So lots of check-ins, staff meetings, pass along any positive feedback that you can, and then try to connect them with inpatient units when possible by introducing them to staff, maybe bringing them up for some in-services. We knew this would be a challenge. Patients are used to anonymity when accessing an OPS, but that's not always feasible in hospital because we do need to access their online chart in case of an emergency. So we only chart in their chart when absolutely necessary, and we will ask permission if we have to reach out to their inpatient unit team. And then you will have to set some boundaries likely with the rest of the hospital. So we have had physicians and nurses asking to be informed when their patients arrive, but we've said no to that. And lastly, you will need to reevaluate your procedures as you go. So acknowledge the growing pains here. This is an unfamiliar type of work. Nothing is set in stone, so it's okay to make adjustments once you know more. We found ourselves often saying, well, we'll just have to see how it goes when we open and go from there. So yeah, hopefully there's some helpful tips there. If anyone is looking at opening an OPS inside of their hospital, I'm really more than happy to chat further. I was only one member of the team, so I can also pass along information from my colleagues.
Thank you so much, Carlin. So to our audience, please send any questions you have in Whova. This will be our last Q&A session for this round of lightning talks. Carlin, you have a question in the chat. We have one of our participants, Carla, asking for your email. And while you type that in, if you're comfortable sharing, I have one question for you. What was the most challenging part about starting the OPS at St. Paul's?
Most challenging. I think for us initially, probably the most challenging in opening was just we were really crunched for time, and it felt like everything was taking a long time to get put through, like all of our you have to create all your new procedures, and we were really on a fixed deadline because we didn't want any gaps in services once the Thomas Donaghy OPS left. So we wanted to be open by the time they left. So I think for us, we created quite a time crunch. But if you don't have that time crunch per se, a lot of the problems that we had, I think, could be mitigated. Gaining organizational support is definitely going to be one. So I think, seeking out any opportunities you can to provide education and connect with other departments and areas of the hospital is really important. So yeah, I would say if you have the time, like I said, running in services on units, Once the staff had more education and in services, I found them so much more supportive and a lot more comfortable around the whole idea of an OPS. I think some people really have a hard time wrapping their head around knowing that the patients are using substances down there within the hospital and then coming back up to the wards. So I think just the education piece around that.
Thank you so much for sharing, Carlin. Next question I have for you is, how would the process of starting an OPS differ in a rural setting?
If this is like a rural sort of hospital setting, I mean, I don't think it would, you'd have less sort of resources available as far as staff potentially. But I think a lot of the steps would really be the same. So if that person is looking for more details, I'm happy to connect via email, but I can't think of specifically why that would be different. It might be more appropriate to go with more of like the EOPS model though, in that type of setting, depending on the location.
Thank you so much for clarifying, Carlin. The next question I have for you is, what strategies can be used to create culture shifts and staff reflection about values and beliefs about substance use?
That's a good question. Again, though, I will just go back to education. I think I work on a unit where we regularly work with folks who use substances, so it's not an unfamiliar setting for the staff I work with, but going up to say like the surgical units and other areas of the hospital, that this is not sort of their comfort level. Just realizing that generally people are pretty open to this. They just don't have the information and the knowledge around it. So I think education is really the key to getting people on board.
Thank you, Carlin. The next question I have is, can people use any substance or route, i.e. smoking / injecting at the OPS?
Yeah, thanks. I can clarify that. So no, we don't have an inhalation room. It's just for injecting. We do offer safer smoking supplies to go, but unfortunately, we don't have capacity to have an inhalation room.
Thank you for answering that question. The next question I have is, did you say that you don't let hospital staff know when a patient is at the hospital OPS? If so, what is the rationale?
Yeah, so we are trying to maintain as much anonymity as possible. So if patients are freely able to come down to our site when they're admitted to the hospital, or if they're an outpatient and say they're coming for outpatient IV antibiotics or something and they want to stop in, they are freely able to do that. So patients in our hospital come and go off the units all the time, unless of course they're on like they're certified or something. But so yeah, we don't see a need to inform the unit if a patient arrives. And we know that that would be a very big barrier for patients accessing the site. So that's really the main rationale is the barrier there.
Thank you, Carlin.
Add to that though, we do inform the units if there is like a safety concern or if there has been an overdose. We contact the unit. So the patients do have an understanding that if there's a medical emergency or we deem that it's safest for staff or for the patient to inform their primary care team, we will.
Amazing. Thank you so much, Carlin. The next question I have is regarding funding. So where did you find funding to run this initiative?
That's a great question. And I wasn't really involved in that, that beginning process. The director of our program, Scott Harrison, was the wonderful man who got funding for us. So if anyone, again, you could reach out to me and I could potentially get you in touch with him around how he sort of secured that. I mean, when we initially opened, we were like a sort of pilot project. Like we only secured funding for 6 months to start, and we collected data and I think showing our number of visits and the need for this, we got extended now for another 8 months, but we're still not technically permanent.
Thanks so much, Carlin. So I have another question. Have you seen a decrease or change in patients leaving the hospital AMA with the implementation of the in-hospital OPS?
Yeah, great question. There's a lot of data points that we do want to track. We did have the good fortune of having an OPS on hospital grounds prior to us opening. So I think we will see a less dramatic shift, as I would imagine sites who have had nothing available on site. But that is one piece that we want to track. We're also trying to track sort of reduction in substance use at the bedside, because that still does happen sometimes, and track overdoses that might be happening in other areas of the hospital still if people aren't able to access the site. So there's a lot of data points and really important to collect that data. But at this time, I don't have data on that. We have been open now for about 5 months. So that's something that we will be looking at collecting.
Thank you for answering that question, Carlin. I have another question for you. So I may have missed this, but was there a difference between staff uptake on Med/Surg and or mental health units and or your educational approach?
Not sure if I understand the question correctly. No, I mean, we haven't connected as much with the inpatient mental health units, to be honest, because the patients there tend to not be able to come to the site because they're often on a locked unit. I suppose if they were out on a pass, they could come to the site, but we haven't really had that come up as much. So we haven't focused on providing education specifically related to the OPS. I think there's definitely room for education around substance use disorders for those units, but we haven't connected with them around the OPS specifically.
Thank you so much, Carlin. You also had one of the participants. Thank you for an interesting presentation on the Hoover Q&A. I have one last question for you. Would you be able to elaborate on how you will facilitate patient confidentiality throughout the process?
Yeah, so we do have a sign-in sheet, as all the OPSs in the Lower Mainland have. It's the same one that other sites use, so patients are used to this. Most sites, though, you can use a handle, which we don't allow. Because we do need, and we explain if there's ever a concern around that, we explain it's because if there's an emergency, we have to get access to your online medical chart, and most of the time that's okay. We do white out their names later on though, so that's not kept for a long period of time, and then when I send in the data, it's only initials, as other sites do. So we try to keep privacy and confidentiality there. Like I said, I have had requests of like, the physician team wants to know when a patient's accessing the site, and we've had to say no to that will be a barrier. We have privacy curtains up so that when people come into the site, because it is in quite a central location of the hospital, that they're not, that people aren't just watching them as they walk by. Yeah, I hope that answered the question a little bit.
Amazing. Thank you so much, Carlin, for your presentation and for all your answers. So before I conclude today's session, I wanted to remind everyone to vote for their favorite talk. The poll will be open on Whova during the next break, and the winner of this session will be announced at today's wrap-up at 3:45 p.m. As well, I wanted to encourage everyone to check out the poster booth during the break, which will happen up next between 10:50 a.m. to 11:20 p.m. PST. And